Good afternoon, everyone, and thank you so much for joining us today for Advocates for Ohio's Future. We will be talking today on a webinar about Ohio Medicaid's EPSDT program, also commonly known as Healthchek. We have a great group of experts with us today, partners with AOF, here to talk about some of the different parts of the program, some services that are available to our kids on Ohio Medicaid, as well as some ways we can improve the program to make sure these kids are having the best care and growth if possible. Presenters today, again, we have a great group of experts with us. We have Graham Bowman from the Ohio Poverty Law Center, Kristen Hildebrandt from Disability Rights Ohio, Kate McGarvey from Ohio State Legal Services Association, and Teresa Lample from the Ohio Council of Behavioral Health and Family Services Providers. All right, I'm going to hand this over to Graham Bowman. He's going to tell us a little bit more about why we decided that now is the time to start talking about the EPSDT program and why it's important today.
Thanks, Kelsey. This is Graham Bowman with the Ohio Poverty Law Center. And so what we do is we partner with legal services agencies throughout the state and try to respond to some of the systemic issues they're seeing in their practice. And one thing that comes up time and time again in my conversations with legal aid attorneys that work with children is the EPSDT Medicaid benefit. So you're going to hear later about what that benefit is and how it helps children, but the one thing I want to point out is that EPSDT is different than other benefits that children receive through Medicaid, like dental care or other things, that really it could be considered almost its own program in terms of the scope of what it provides. And so you see this slide here showing that children in Ohio are losing health insurance at an alarming rate. And the way these numbers work out is about 12,000 children and infants last year went without health insurance. What else this slide doesn't show you is that is a dramatic increase from the year before. It was about a 40% increase in the amount of children that went without coverage, making Ohio one of the kind of worst states in the country when it came to coverage losses. Now, that could be its own entire webinar. We're not going to get into the reasons for that today, but it reflects some systemic issues in Ohio when it comes to children's ability to access services when they have increased health needs. Many of you participants in this webinar have probably heard about increased incidences of lead poisoning among children in Ohio, or families that are required to relinquish custody of their children in order to have their children be able to access services. So there's a lot of work to be done in Ohio to make it easier for children and families to access these services. And the reason we're doing this webinar today is, first and foremost, we have an administration that really has been prioritizing children's access to services, and so there's just a lot of opportunity to improve some of these long-term issues. But also, the Department of Medicaid has made the decision to reprocure its managed care contracts. So managed care is the system that Medicaid uses to administer most Medicaid benefits, especially this EPSDT program. And those contracts with the kind of the private entities that administer that are going to be rewritten this year. It's a process that started last year. We'll talk about it a little bit more later. So keep that in mind as you hear our presenters speak about these benefits, is that there is going to be opportunities to improve this benefit and improve children's access to services. And so with that, I believe we are turning it over to Kristen to talk about kind of what Ohio EPSDT is from DRO's perspective.
Thank you, Graham. You can go ahead and move to the next slide. So EPSDT stands for Early and Periodic Screening, Diagnostic and Treatment. It is a federal Medicaid program which provides special coverage and benefits to children aged birth up to age 21. It's not a new program. It's been around since 1967, and when it was first introduced and now, it still has the same purpose, and that is that it's designed to find and treat health problems early so that children have better life outcomes, so they reach their fullest development potential because we have identified problems and provided treatment for them as early as possible. There is sort of a central thrust of this program, and that is that it provides more services to children than adults would typically get through a Medicaid program, with the idea, of course, being we want to provide whatever services are medically necessary for children as early as possible. There is no separate or different eligibility process for EPSDT. You can think of it as the child component of Medicaid, but as long as a child is eligible for Medicaid through one of the normal routes of getting eligible, or they might have a waiver and are eligible that way, they are entitled to this expanded program and coverage called EPSDT. Next slide. All right, so I'm going to sort of walk through the requirements of the federal EPSDT program, and then towards the end of my presentation, I'll get into some of the specifics about Ohio. But of course, the S in the EPSDT stands for screening, and it's one of the central of things required by this program. And the purpose, of course, of these screenings is to detect as early as possible any physical or mental conditions that children might have that need to be treated. There are two kinds of screenings that occur in EPSDT. One is a periodic screen, and the other is interperiodic screens. The periodic screens are established by something called Bright Futures, which is something that is developed through the American Academy of Pediatrics. You can Google it, and you can find a chart online that establishes the periodicity of when a child should visit a primary care physician or other providers to get screens of their development. As you would expect, the screen has many more screens as when children are young. Some people think of them as well-child visits, but the idea is that parents need to take their children periodically to providers to make sure that they are growing and developing correctly. The other component is an interperiodic screen, and that is if a problem is identified at one of these regular screenings that are scheduled by the Bright Futures chart, then that child can be screened further for that, whatever that condition is that was identified, and then follow-up services would be provided. Next. All right, so the screening in EPSDT is supposed to be comprehensive. It includes comprehensive health and developmental history, an unclothed physical exam, any appropriate immunizations that the child might need, laboratory tests, and then another component of it is to provide health education to the family around whatever was discovered at that screening visit. All right, so also EPSDT requires children to get vision services. At a minimum, children are entitled to diagnosis and treatment for defects in vision, including eyeglasses, and they too are provided according to the periodicity schedule that's established by the Bright Futures, and of course at any other intervals that might be medically necessary for a child. These vision services on this slide are minimum, so if something is identified for a child as medically necessary, EPSDT should cover that service. The same is required for hearing services at a minimum that requires diagnosis and treatment for defects in hearing, and including hearing aids. But again, anything that's medically necessary could be provided under EPSDT. Dental services are also required. They are required to relieve any pain or infections, restore teeth that need restoration, and general maintenance of dental health. and they can't be limited to emergency services. So one of the things to remember about EPSDT is that the general limits on amount, scope, and duration of services provided through Medicaid generally aren't applicable to children through EPSDT. If a child needs to have something more than what's listed on this slide and it's medically necessary, it should be provided through EPSDT. All right, so the D of EPSDT is diagnosis. And typically what happens is when a child is at a provider for one of these screens and that person discovers that something needs to be addressed, that provider then is required to refer that child, to diagnose what's going on with that child and either treat that child or refer that child for any additional diagnosis services that that child might need. The law requires that this be done in a timely fashion, so without any unnecessary delay, there needs to be follow-up to ensure that that child receives whatever diagnosis services or evaluation that they might need. Again, throughout this whole program, doing things in a timely fashion and treating kids as early as possible is sort of the bedrock of the services. All right, so the big thing about EPSDT is the T, the treatment component of it. The treatment piece is really what sets this program aside because it is very broadly defined for children. Federal law requires children who are Medicaid eligible to get any necessary health care, diagnosis services, treatment, and other measures that are services that are provided through the federal Medicaid program when they are needed to correct or ameliorate defects in physical and mental illnesses and conditions discovered by the screening services. Okay, next slide. All right, so this is a much broader standard than the standard that is provided to adults under the Medicaid program. So anybody who's familiar with the Medicaid program for adults understands that there are amount, scope, and duration limits that are connected to whatever services that the person is getting, and in fact that states have leeway in determining which of the non-mandatory services they're going to provide to adults. Under EPSDT, a state must provide all of the services that are available under federal Medicaid to children, regardless of whether they cover those services for adults in the state. So kids get more. Going back to that initial slide, that if it is a federal Medicaid service and the child needs it, then EPSDT would cover it for that particular child. All right, there are also other sort of program obligations that states have when they administer their EPSDT program. And one of the big ones is to inform all of the people who are eligible under the program of the program and the benefits that are available through that program, including appropriate immunizations. The state also is required to provide or arrange for the provision of screening services for all children who qualify under EPSDT, and arrange, either directly or through some kind of a referral, for the corrective treatment that is identified as being medically necessary based on those health screenings that occur. The other thing that the state needs to do is report the performance of the program, of their program as a whole, to the Centers for Medicaid, for CMS. And there's this form, which is called a CMS 416 form, that every state fills out and sends to the federal government about their performance according to the program. There's also available online, if you're interested in statistics and data, compilations of how states perform against each other. And I can tell you that there are some trends in how states do in this program. One of the trends is that what's called the screening ratio, or how well do we ensure that that kids get screens according to that Bright Futures chart, that is better for younger children, and the screening ratio goes down as kids get older. So in general, the state does a pretty good job of making sure that young children in the first couple of years of their lives are going to well-child checkups, but older children not so much. So that's one of the trends we see, that we may have Medicaid-eligible older children, particularly ages 12 to 15, that aren't getting the necessary screening services according to EPSDT. Okay, so the state has to send to the federal government the number of children who get those screenings that we're talking about, how many children are referred for corrective treatment, numbers of children getting dental services, and also how the state is doing in reaching goals that are set by the federal government for the program. All right, so I want to talk a little bit now about Ohio's program and how we implement our EPSDT program. We have chosen to give it a special name, and that name is Healthchek, and it is supposed to be implementing the federal Medicaid EPSDT requirements. So every state that participates in Medicaid also has this child component. It's a required thing for every state to do. So if a child is Medicaid eligible in Ohio and they can't access a specific service or a more of a particular service that they're looking for through a state plan service or a waiver or a managed care program, then that child should be seeking to access that through Ohio's Healthchek program if that service is medically necessary. So that's the good thing to remember. If you are working with a child who's trying to access additional therapy or additional nursing hours or additional whatever the service might be, and the particular program they're involved in, maybe it's a waiver program, maybe it's a County Board of DD waiver program, is saying the child can't get more, that's when you need to be asking about expanded services available through EPSDT or the Healthchek program. Okay, so one thing to know about EPSDT is that those limits that you may hear about that are applicable to adults in Medicaid are not applicable to children. So limits on amount of services available, the scope of the service or the duration of the service are not applicable to children who are eligible for Medicaid if the service they're asking for is medically necessary. Now, the state is allowed to implement reasonable prior authorization procedures for the request for additional services under EPSDT or Healthchek, but they can't be implemented in a way that would deny a child medically necessary service that would otherwise be available on the federal Medicaid menu. Okay, Healthchek is a mandatory set of services, and it's available to all children ages 0 until they reach 21 if they're enrolled in Medicaid. And we commonly think of it as the child health coverage package of Medicaid, even though it's technically not a separate program. It is just an expanded standard that's applied to kids. And I just have the Ohio Administrative Code section here for you if you're interested in looking at Ohio's rules on it. The rules are not lengthy. We used to have a bunch of different rules around Healthchek in Ohio, but not too long ago, Ohio revised it so that there aren't so many. But there's the site if you ever want to look it up. All right, so the standard of medical necessity is expanded for children under EPSDT. We already talked about the federal standard, and that is access to any of the federal Medicaid services that are necessary to correct or ameliorate defects in physical and mental illnesses and conditions that are discovered by either the periodic or an interperiodic screen. Ohio's definition of medical necessity does include a separate standard of medical necessity for children. This has not always been true. For many years, Ohio had one medical necessity standard which did not incorporate this expanded coverage that is available to children. So it's good for you to know that Ohio Administrative Code 5160-1-01, which is our state's medical necessity definition, has this separate standard for children. And it defines medical necessity for children. I'm not going to read this whole thing, but you can see that it incorporates the correct or ameliorate standard that we see in federal law. And it also does a nice job, I think, of expanding the types of illness, injury, disease, and conditions that a child might have that could be covered under EPSDT or Healthchek in Ohio. And we've talked about this several times already. The purpose of EPSDT is to prevent the onset or worsening of disability and illness in children and to treat them as early as possible so they have the best life outcomes. The standard of coverage under EPSDT is necessarily broad because we want to ensure that the coverage levels are enough to not just treat a child's already existing condition, but also to prevent the development or worsening of conditions, illnesses, and disabilities. This is really critical language, particularly for a lot of the people that I work with, children with disabilities. It's often important to provide services to them that are sort of maintaining whatever progress and strides that they have made. And so this standard of EPSDT that allows us to get services to prevent the development or worsening of conditions is one way that we can access services for those children. All right, so I want to talk to you a little bit about the history of some lawsuits in Ohio about EPSDT. There have been a couple that have used the federal EPSDT law as claims. Probably the biggest one was a class action lawsuit filed in 2005. At the end of it, I think it was called GD versus Raleigh, but it changed names every time a new director of JFS at the time, Department of Medicaid now, came in. And that lawsuit really focused on two things. One, that at the time, the state of Ohio was not, or was considered to not be doing a good job informing families about the EPSDT program and the benefits available through it. And so the discovery in the case showed that a lot of families did not understand that EPSDT was available, didn't know how to access those services, and and weren't getting the services that they needed. In fact, were being told that they weren't eligible or couldn't receive those services. So this case was filed on behalf of all children in the state, and in 2011, there was a partial settlement of that case. The partial settlement required the defendant to redo the way that they informed families about EPSDT in a variety of different ways. In the notices that they sent out to families about periodic screenings, and about the information that they sent, and how they trained their Healthchek coordinators at the county level, and a variety of other ways, better information on the website, that kind of a thing. There was, however, a remaining issue. Whoops, go back to the, yeah, thanks. There was a remaining issue in the case because the other part of the case was that Ohio didn't have a special definition of medical necessity for children. That, as I said before, their state's definition was a definition only applicable to adults. So the remaining issue in the case then was whether Ohio's definition of medical necessity conflicted with those federal EPSDT requirements to include that language about correct or ameliorate. That issue went to the case went to summary judgment, and it was dismissed on other grounds. So when the case was dismissed, that issue remained. That advocates felt that Ohio's definition of medical necessity didn't comply with federal law. Fortunately, the definition was subsequently changed through advocacy by a variety of different advocates, child advocates, with the Department of Medicaid, and that's why we have the definition that I've talked to you about today that includes a special child definition of medical necessity for Medicaid. Okay, another case in Ohio that involved EPSDT, this case, GD versus Jones-Kelly, is just another iteration of the case that I'm talking to you about now because I told you that were various different name changes on the case. I just have this slide here to point out to you that there were some findings by the court throughout the history of this case. And one of them is beneficial, and that is that it found that the EPSDT provision of Medicaid was privately enforceable in court. So what that essentially means is it gives families the ability to enforce access to EPSDT services through the court. All right, so the other lawsuit that raised the issue of EPSDT in Ohio was a case called Parents League for Effective Autism Services, or PLEAS, versus Jones-Kelly, and this case was brought because the state was attempting to change some of the rules or implement a couple of rules that would restrict EPSDT's coverage of rehabilitative services. The services at issue in this case were ABA services for children with autism. So a case was brought to ask the court to stop the state from implementing these rules that would limit the coverage of ABA services under the EPSDT benefit. And the court ruled in favor of families in this case, and it determined that EPSDT requires the coverage of ABA services as a rehabilitative services for children with autism. So it also determined that parents have a private right of action also to bring EPSDT claims in the court. So a critically important decision for families in Ohio. All right, so Ohio is not the only state that has had EPSDT litigation. In fact, there are many states that have had and are currently engaged in EPSDT litigation. There is good information available on online about what is currently going on and what kinds of cases have occurred, and I think I have a site at the end of my presentation about that. But I just wanted to talk about some of the common themes that you see in litigation in this area. One is accessing community or evidence-based services. So the PLEAS case I was talking to you about clearly was about an evidence-based service like applied behavioral analysis for a particular group of children, kids with autism. So you see a lot of cases throughout the country that focus on this issue. Other cases focus on accessing services in the community, so in particular mental health services for kids with who need that, to be able to access that in a community setting through EPSDT. The other kinds of cases you see are cases involving whether or not Medicaid, well, actually what is Medicaid's role in this process, whether they're a payer or a provider of services. And if you recall early on in this presentation, I talked about states having to provide or arrange for services. So that's the language that is litigated in the country around what really does Medicaid have to do? Actually pay for the service or provide the service or just arrange for it. Other cases focus on the treatment component of EPSDT. So there are states that sort of implement EPSDT programs, like they might do the informing piece and they do the screening piece, but when it comes to the treatment component of EPSDT, it's not implemented as broadly as it should be. And in fact, Ohio was in that position before expanding their definition of medical necessity, where their definition resulted in denials of services for children because it didn't include that expansive correct or ameliorate language. So there's litigation in other states on that issue as well. And then, of course, the private right of action. So courts throughout the country have looked at the various different parts of the Medicaid program and whether or not there's a private right of action around that, meaning whether or not a person can sue because the state isn't doing something that correctly in a Medicaid program. So courts have found that certain parts of the Medicaid statute are enforceable by a private person and some parts of it are not. So there is litigation around that in the EPSDT realm. And in fact, that is the primary recent trend in EPSDT litigation, whether or not the EPSDT component is privately enforceable. For our purposes, for those of us in Ohio, the courts have already spoken that it is, but other states have not gotten such a clear answer on that issue. So here's the citations for more information on litigation across the state. This comes from the National Health Law Project. There are people there who are very well versed in EPSDT and follow what's going on throughout the country very closely. So there's some really nice fact sheets on EPSDT litigation, what's happening in those cases, and the types of issues that they are addressing.
Great. Thank you so much, Kristen. What a great bunch of information. And folks who are joining us in the webinar at any time, please feel free. On the left-hand side of your screen, there should be an attendee chat option. If you have any questions, feel free to type those in, and we will go ahead and answer them as they arrive. But with that being said, we're going to go ahead and move on to Kate McGarvey, who will be telling us a little bit more about the experience of consumers and families who are using EPSTD right now.
Thank you. All right, go ahead and go on to the next slide. Oh, thank you for asking me to be here. I appreciate the opportunity to talk a little bit about what we see in terms of consumers who contact our office and what some of those recurring issues are. My focus really is on that T, or the treatment part of EPSDT, largely because that's often when folks come to us, is when a service has been denied or reduced, and at that point may know to contact our office. That is not to say that there aren't issues for consumers on the screening side of things. I think there's always room for improvement there. Graham mentioned lead. I know that one of the things that we have been looking at is how to make sure, when folks may take a child to a doctor's office and get a finger prick, which indicates there may be elevated levels, how are we making sure that those children are making it to a facility that can do a blood draw to check to see, was that correct? Is there an elevated blood level? And then can be sure that they are getting the services to be treated for that. But with that said, I really will focus largely on the T. The first thing that I really want to stress is one of the biggest issues that we see with EPSDT is an overall lack of information or lack of knowledge. And I would say that that runs the entire gamut. Most consumers do not understand that there are additional services available to children through EPSDT that may not otherwise be covered for adults. They don't know to raise it with the provider, and they don't know to raise it on appeal. So if they're able to contact our office or Kristen's office at DRO and some other folks, they may get that information, but oftentimes they don't have that, and so those issues are missed, or they assume that the determination was correct when it was denied and just don't pursue it any further. Similarly, we have still found that many providers may not understand the additional protections through EPSDT as well. And so we've tried to work with folks when something is denied to explain that, and then also ensure that that information is included in prior auth requests and as a part of that process. Similarly, there is a learning curve for managed care plans around EPSDT, and we have run into this challenge with all of the plans in terms of really understanding what is the entire package that's available through EPSDT and how is it being implemented. I think that part of that misconception probably does come from the name itself. I know Kristen said, that Ohio has decided to call our program Healthchek, and of course that name itself implies that the services are more on the screening side and less on the treatment side. And so I do think there is some common misperception as to what all is included in that benefit. So I was happy to have the opportunity to do the webinar today, and I think that the more that all of us can talk about what is available, that will be better in the long run for consumers. Flip to the next slide. Okay, so I wanted to talk about some specific issues that we see on the treatment side. The first is residential services for children. And what we have seen over time is that we will see cases where a child is in need of oftentimes psychiatric inpatient services and will be told that that is not a covered service through Medicaid, and instead told that the child needs to go to children's services and that the services can be provided that way. That should not be happening. If the child is Medicaid eligible and they require the level of care for a psychiatric residential treatment facility, that should be covered through Medicaid because, as Kristen said, it is coverable under Medicaid. So even if it is not currently something that is in the Ohio state plan, because it is coverable and because it is medically necessary for that child, it should be provided. So we have had a number of those cases, many of which we have been able to get coverage for the child without the need for custody relinquishment, although we recognize that there are many folks who don't come to us or who we're not able to serve, and wanting to make sure that people know that they shouldn't have to go through that process to get their child the care that they need. With residential services, we've also had some cases where it may be a specific service that isn't available in state. We had a couple of eating disorder cases, for example, where it required both residential treatment and with some specialization that was not available locally. And while the ideal is never to send a child further away, if that's where that care is medically necessary, that does need to be covered as well. The other really big area that we see cases are around home care services for children. And Kristen mentioned this as well, that if the services are not available, for example, through the waiver that the child is on, but they are medically necessary, they should be provided to the family. And so we will see this sometimes where a managed care plan might reduce the home care services that a family is getting. The family may be on the wait list for a waiver, but if those services are medically necessary, they should be provided. Similarly, we've had some cases where the waiver rules may say this care needs to be delegated from a nurse to a home aide, and that's the rules under the waiver. Well, if it's a child and if it's medically necessary that those particular services be done by a nurse, our argument is that under EPSDT they should be covered, and whether they're covered through this, through the state separately from the waiver is a different issue. The other thing that comes up regularly here is that arranging care piece that Kristen mentioned. So we'll oftentimes see a family who is told, yeah, you're eligible for however many hours of home care services. Here's a list of folks you should call. And oftentimes families will make it through that list without any success, and they'll learn that each of those places are full, or they won't travel to their area, or they don't, we see this a lot, they don't have specialization with kids, especially kids with complex healthcare needs. The state or the managed care plan does need to be working with those families under EPSDT to help arrange that care. It's not merely passing it off, but it is helping to arrange that care so that those services are provided. All right, next slide. Probably the two other biggest areas where we see service issues are around durable medical equipment and dental services. So durable medical equipment, even if the durable medical equipment wouldn't be provided to adults under Medicaid, if it's medically necessary for the Medicaid eligible child, it should be provided. So we've had cases that have involved modified car seats or car seats that need to be modified, covered through Medicaid. Wheelchairs, we've seen a number of wheelchair cases where it may be under the regular Medicaid rules for adults that the wheelchair is only provided every so many years. Well, the child has grown more than that, or other things have changed, so they may need a wheelchair more frequently. That should be provided under EPSDT if it is medically necessary. Shower chairs, other similar things can be provided when medically necessary, even if not otherwise noted. And then dental services. This comes up oftentimes with orthodontics. So we may see a kid where the dentist or orthodontist is saying, this kid really needs braces, and it's medically necessary. A lot of those cases involve pain, where the child has chronic pain, has chronic difficulty eating, maybe is losing weight because of that difficulty. And while braces would not be covered if they were an adult, because they're a child, because they're medically necessary, they should be covered under EPSDT. What we see in some of these cases is that oftentimes when we get to the state hearing, the rules that the managed care plans are using may either be the adult rules in the administrative code, or they may have some internal guidelines that they use, which they're using to deny the client. But really, what they should be doing and what we're arguing is that it should be covered under that medically necessary definition that Kristen gave earlier. All right, one more slide, and then I'll turn it over to Teresa. Okay, so this last one is medical treatments. Kristen talked about ABA. We've had cases with particular medications. One that always sticks in my mind is for a case for a child who needed a human growth hormone. Something that wouldn't otherwise have been covered under Ohio's plan, but was coverable under Medicaid and had been denied. And so we were able to get that boy the medication and the growth hormone through EPSDT. So I would encourage you in thinking about it to think about sort of the whole range of services that can be provided by Medicaid, whether it's home care, whether it's equipment, whether it's medication, and make sure that definition of medical necessity is something that is on folks' mind and not necessarily what the specific OAC section is for that service or what the managed care plan's internal guidelines are. So I think that is it.
Fantastic. Thank you so much, Kate. Now, that was a great explanation of what some of our families are facing. And now we will turn it over to Teresa Lample, our last bit of our presentation here. Go ahead and take it away.
And thank you for having me on this panel. I'm going to talk a little bit about EPSDT from a provider perspective and really kind of talk through some of the barriers and challenges that providers are experiencing as they try to deliver services knowing that EPSDT is a very rich benefit and intended to help our children, particularly our children covered by Medicaid, because by virtue of being in Medicaid, we know they're experiencing poverty. We know that they are also likely to have experienced other adverse childhood events, which puts them more at risk of experiencing more chronic health conditions, behavioral health conditions, and addiction as they age, as they develop through their normal development. So to just think about the provider perspective, you can go ahead and go to the next slide. You're going to hear some repetitive themes, which I think really leads to, what we'll talk about at the end, which are some of our recommendations. So for providers, again, like you've heard for parents and even managed care, Ohio's EPSDT Healthchek is largely viewed as that preventative well child care program. We talk about Bright Futures, and when they talk about Bright Futures, it really focuses on those early screenings and kind of well child visits, and getting to maybe the diagnosis part. And that's kind of where it stops. But even within that, from a provider perspective, we pick and choose parts of what gets screened. So I think that's kind of one of the biggest challenges we face generally as providers, but also with the managed care plans and even how the program is explained to parents. The other that I would say is just generally as a provider, there is a lack of information about EPSDT, and more importantly, a lack of a defined process for how to access services under this benefit. So if I identify through screening and assessment that I have a diagnosis and a child needs something that is not part of the regular menu of services that Medicaid covers, the question becomes, well, how do I even go about accessing it? Where do I start? And that information is not readily available. So that becomes another issue that I think we have a much more to do to educate parents, providers, and also managed care plans, and then having a consistent process is one of the big barriers. This next, I want to talk about what there's limited routine reimbursement for screening and assessment. So I'm actually going to talk a little bit about all of the letters, the E, P, S, the D, and the T, because I think the screening and assessment is one that what's routinely covered. And again, EPSDT says that we should be able to do more, but what's routinely covered and what happens as a provider is because it is you don't know where to go, and it is administratively complicated and time-consuming to figure out how to get something covered when you're doing something beyond the norm. What we default to is what's on the menu. So what's on the menu for screening and assessment is typically those assessments have to be office-based. So there's been a lot of effort to talk about doing more screening, particularly for risk behaviors, for alcohol and tobacco use, for suicide in our schools, for bullying. All of those things are covered as screenings that could be done under Bright Futures, but typically the routine benefit covers it in an office setting. If I, as a licensed social worker, go into a school, I'm qualified to do the screening, but the current benefit doesn't say it's covered. So how do I provide access to that under EPSDT? I think for behavioral health in particular, screening is typically treated as a singular issue rather than looking at it as multiple conditions. So I've listed some of the typical ones. So, the challenge becomes if screening is viewed as limited to primary care and I've got complicated issues, I don't either A, have time, or B, have a reimbursement strategy to get paid for multiple screenings. And then when I do a screening, typically the way the screening is routinely reimbursed is one per year, or one per 6 months, or one per whatever is the Bright Future schedule. Yet for depression, for example, if I use the screening tool, which is called the PHQ-9, it looks at my symptoms in a 2-week period. And so if I see a practitioner and have the screen, and a month later we want to see if my feelings, thoughts, and behaviors have changed, and I screen again, under EPSDT it should be paid. but under the routine, it may not be. So these are some examples of, I think, the challenges we see with screening and assessment. I would also say that, screening and assessment usually is what then helps arrive at a diagnosis. And one other thing that we also commonly see is if we have multiple diagnoses, sometimes what will happen is from a payment perspective, a payer may choose to focus on, one diagnosis over the other. So, an example might be, oh, you're experiencing obsessive compulsive behaviors, but you also have an autism spectrum diagnosis. So we're going to say this is not medically necessary because of the autism diagnosis, but really, but it is medically necessary if I was looking at the obsessive compulsive behavior. And so those become other issues that we also have to work through from a diagnosis perspective. The next one I would say is, one of the challenges is limited providers of some services. In talking with particularly the behavioral health providers and working with kids, what we find typically is, finding dental services is a significant challenge. So even when it's covered, how do we find that? Both Kristen and Kate talked about home health services, and those are really true in terms of being able to access the level, the intensity, and with the right practitioner. I think I also, coming from a behavioral health perspective, we struggle with being able to find and identify and cover home health-like services for children who are being discharged from an inpatient psychiatric stay who may not need residential treatment but really need more supported home. And we don't have a corollary of home health in necessarily the behavioral health benefit. So how do we make that service available? And then the other one that came up pretty frequently was interpreters and being able to access and cover and have that service available. And then generally speaking, I think overall, we have healthcare workforce shortages, and that's impacting access to nursing, to psychiatry, mental health, addiction, and I think pediatric services generally. So that whole piece about finding the workforce, even if you can get the coverage, workforce still becomes an issue and challenge that we face in terms of making those connections and getting the access to the services that the child or family needs. Kind of moving through that, let's say that, as a provider, I do figure out how to make access the service. Medicaid managed care, as Kristen talked about, the services can be provided, but plans and the state can do a review for medical necessity and then require prior authorization. However, the processes themselves generally are long, they're cumbersome, they challenge the amount, scope, and duration that you're seeking, and when you're trying to do that outside of the usual menu of care, many times there's a lot of confusion and challenge about whether or not you can even request the service, again, because there's a lack of understanding or lack of knowledge of what's permissive under EPSDT for services to children. So this is, again, another example kind of within the system structure. The systems are generally designed to treat adults. Even though the Medicaid program covers a large majority of children, it is really important to understand that most of the time the models are based on covering services to adults. And so the default position is, well, this is just what we do. The denial and appeal processes, once you start into seeking those services, become incredibly burdensome. They're time-consuming, they're costly, they're complex. Many times it involves pulling in legal counsel or, as you've heard today, moving to a point of litigation. And frankly, through the general denial and appeals processes, many times the provider is unsuccessful or the family is unsuccessful. And what that results in is challenges with, just basic patient and family engagement in those appeals and those denial processes. Because again, our families who are covered by Medicaid often do not have the luxury of time. That's one of the major challenges, in living in a system of poverty is the time that it takes to just accomplish basic tasks. And so having to sit through appeals, having to continue to talk about the same process really results in a sense of hopelessness and fatigue and a sense of failure, and it's just easier to give up. And so that's one of the big challenges we experience as well. And then finally, in that kind of that same vein, many times as you're going through these appeals and denials, what we hear or find is that the needs of that particular child increase. Their condition deteriorates, and then they need a different level of care, or now they've deteriorated to where they need something new. And if what they need that's new isn't a standard covered service, then you're back to starting the process over. And so that's one of the challenges that we hear as well. On the other side, if you do make it through the process and as a provider you get to the end and they say, yes, there's an agreement, they will cover the service, then the challenge becomes, well, okay, you've agreed to cover it, but what is the reimbursement that you're going to provide? And going through a non-standard process of negotiating a rate for a service that's not usual, not typical, different staffing that's many times not understood, and at the end of the day, usually the rate that's offered is not sufficient to cover the staffing and the service delivery of the child that's needed. So that then becomes yet another barrier, and either the provider or the family or the advocates working with that particular family are all then, again, looking to try to put together resources to be able to continue to meet that need. When we talk about specific services, again, I think the challenges, and we've talked about most of these already, really come back to when you think about what is the typical reimbursement, and both Kristen and Kate talked about this, when it comes to residential treatment, Ohio's Medicaid reimbursement is limited to paying for the treatment services. It doesn't cover the need for additional staffing, and it doesn't cover room and board. So how we put together a recommendation or a request for additional services to meet that service, and so that kids can get the service if that's the level of care that they need, without resulting in a custody relinquishment position is really one of the challenges that we're trying to overcome. I've talked a little bit about home-based services and the limited provider capacity, or the opportunity for 24-hour supervision and care, nursing, or support. And I think even when we talk about things like respite services, or family counseling and support, there are many evidence-based support services that are available, such as respite, coaching, peer support, and they're not necessarily readily available for kids or their parents in Ohio, but they are evidence-based. And so how do we come back and make those available? We do have a limited respite benefit, but it doesn't provide coverage if, during the time that the child may be sleeping. Yet that might be the time, because they have intermittent sleep, that you just need someone there to make sure that if they do awaken, that there is active and ongoing supervision, because they may have behaviors that will be challenging if they're not supervised readily. So these are some of the key areas that you've heard mentioned, and we would agree, all of these have opportunities to be covered under EPSDT, but because they're not part of the routine menu in a robust way, and we don't know what the specific pathway is to access EPSDT through the various managed care plans, it becomes a real challenge as a provider to help families and these kids get what they need.
Teresa, thank you so much for that perspective from the providers. Very briefly, we're going to throw it back to Graham Bowman from the Ohio Poverty Law Center to talk about why some of these ideas and talking about some of these changes is so important right now.
Thanks, Kelsey. This is Graham again. So circling back to some of my comments I made at the beginning of the presentation about why we are trying to raise awareness around EPSDT right now, is that the Ohio Department of Medicaid is in the process of rewriting its contracts with the managed care entities that administer the Medicaid program for the vast majority of recipients. So many of the issues that you heard Teresa, Kristen, and Kate talk about are affected primarily by decisions made by the managed care companies that are governed by those contracts. So one of the first things that Governor DeWine did once he became sworn in as governor was announce that he was going to take a second look at these managed care contracts. Starting in June, ODM released a request for information to gather public input about the state of the managed care program. In September of 2019, ODM released a report kind of summarizing that feedback they got from both individuals and providers. And many of the issues that you heard about today were things that were systemically raised and that our ODM acknowledges is on their radar, and it's what they are looking at going into these new contracts. Sometime soon, this hasn't happened yet, the Department of Medicaid will have a second round of RFIs that go out specifically to potential managed care companies to respond to some of these issues that have been raised. And the department has been careful to not commit itself to any specific timelines of when these new contracts will be entered into. They're hoping to do that sometime this year, but they've been careful to say that they are going to be deliberate and careful to make sure that there's a smooth transition. And one thing that they've done that us advocates have been happy to see is that they've left the comment period open. So if your agency or program did not submit comments when the RFI was first released, they're still open. So on the slide, you can click that link and go to ODM's website. And we're hoping that for those of you that have an interest in children's access to healthcare services, will make your voices heard. Again, the managed care reprocurement process is large. It's not just focused on children's issues. It's the entire Medicaid program, anything ranging from dental care to chronic health issues to transportation to institutional care. All of those issues will be affected. So we as advocates are hoping to ensure that the importance of the EPSDT program and benefit is not lost in the shuffle as this goes forward. And so with that, I'm going to turn it back over, and our presenters will talk about some of the recommendations their agencies have made during this process.
So thanks for that, Graham. And again, just to echo what Graham said, we hope you will take these recommendations and submit them as things that you hope that the Department of Medicaid will consider as they are moving forward with reprocuring managed care and in the upcoming contract negotiations. So you won't be surprised, I think, by our recommendations, considering you heard over and over what the concerns and challenges are. So the first one really is we need to have consistent EPSDT training and education for both parents, providers, and managed care plans, with easy-to-understand materials, including web-based comments, content, and on the EPSDT benefit as equal to the way they talk about Healthchek. So I think that's really important in making sure that there's a level-set understanding of what it means to serve kids and why it's so critically important, because if we can help our kids develop and reach their fullest potential, regardless of what their medical, behavioral, or emotional challenges might be, that's really what we know is a best practice in terms of getting folks to being, to growing up healthy and well. One of the other recommendations is for Medicaid to establish a single point of contact within the department, such as a family navigator or ombudsman, that sole job is to focus on helping a family or a child navigate the EPSDT benefit, and then require the plans to prominently display that information, to share it with every parent who has a child under 21. So that is one of the things that we would recommend as another thing that we would do to be helpful. Similarly, we would recommend that there be a specialized and expedited EPSDT authorization process through the managed care plans, where they would have a fast track with highly trained staff who are well-versed in the requirements of EPSDT, the medical necessity definition for kids, and that decisions and appeals would be completed within a 48-hour period, And then within that we would make it incredibly easy for families to understand how to request authorization for a service under EPSDT, so that both providers and families can independently say, this is what my child needs, and this is why I believe they need it, and work through that process in an expedited manner. The fourth recommendation we have is we think there needs to be more clear accountability and transparency. Kristen talked about some of the federal requirements for reporting, and we think that's great. We would hope that there would be even more reporting in a more frequent basis, and a look at what services and gaps in availability of services, so that we're making sure that we understand what services are needed, and then doing policy work to make sure if we're seeing gaps in care that we're starting to figure out how to fill those, and maybe even cover some of those things as routine benefits because we're seeing much more need for those services. And then finally, request that there be rule clarification to ensure that EPSDT is clearly listed as an exception to those standard rules when services are provided, and to do that in each section of the code, so that it's clear that that applies anytime you're dealing with children, and really starts to overcome the concept that the program was really designed to treat adults, and children are not little adults. Children are children, and they have different developmental needs and different special needs that we have an obligation to, that the Medicaid program has an obligation to make sure are available.
All right, Teresa, thank you so much. And I want to thank all of our presenters this afternoon for their time and for their expertise on the EPSDT program. It's a little bit difficult to get through, I know, especially from an outsider's perspective, but I'm very grateful, again, our experts for taking the time to give a very thorough explanation from both a provider and a consumer perspective, so that we have an idea of kind of what needs to be done moving forward to improve these services and ensure that, again, our kids, our greatest resource, are getting the services and the treatment that they deserve under Ohio Medicaid. So that does conclude our webinar for this afternoon. We're just a few minutes over, but that's all right. Wanted to let you know, for those who have registered for the webinar, there will be a full slide deck and full recording of the webinar emailed to you shortly. So feel free to share that among colleagues and anyone you feel would be interested in the topic. And once again, we encourage you to take a look at the Medicaid RFI website. That opportunity for feedback and for recommendations is still open. We have included links to both of those resources within the chat section, but we will, of course, email those to you as well. My name is Kelsey Berkfeld, and I am the manager of Advocates for Ohio's Future. And once again, thank you for your time, and we'll see you next time. Have a great afternoon.
Thanks,